Good morning. This is Dr. Nick Tullo, live from New Jersey, here with my Saturday morning clinical live stream. I hope you guys had a great week. I was actually on call last weekend, so I didn't get to do one. But last night I came up with a really great case. This morning I've been up for like 2 hours getting everything set up and, scanning things and making sure that everything, all the lights and stuff are ready. So welcome. For those of you who are new, I see we have a bunch of people watching now. Good morning, Wyatt. Good morning, Chris. Thanks very much for joining me. If you guys want to put a comment, I will try to notice it and respond, but this is an interactive kind of live stream. I started doing this maybe like 5 months ago. So this is my 27th one. This is really terrific. And I just, love being together with you guys on a Saturday morning. As you know, I'm a cardiac electrophysiologist, so my world revolves around electrocardiograms and arrhythmias, and so I tried to present the clinical side of things. What do you do with patients? It's not just about how to read the ECG. I mean, certainly if you need help reading the ECG, down in the comments section, you can click on ECG Academy and kind of take a look at some of the stuff I have on there. Leonardo, Narayan, SpaceFed, thanks so much. Ahmad Brian, I'm glad you're here today. It's always good to see the same people week after week. I mean, this is great. I have my little international audience. It's such a wonderful feeling to know that there are people out there that feel that my videos are valuable. So if you do like this video, make sure you go in the comments section and press the thumbs up button. You also tell your friends to subscribe. There's a link in the comments section below so that you will get notified when I'm going to put these things together. I usually try to send out notifications the night before when I'm trying to figure out what case I'm going to talk about. But, this is an interesting case, and I thought it was funny because I have 3 partners that are general cardiologists, and one of my partners walked into my office one morning and threw a Holter Monitor down on the desk and said, "I think this guy needs a pacemaker." And so that's how this whole thing started. So let me kind of explain the case to you. This is a, let me see, it's a 60-year-old gentleman. He works for a heating company, does plumbing and steam fitting. And he has a history of hypertension, but he was only on amlodipine. And he was doing fine. He went to his regular doctor's office for just a routine check. And his doctor said, "Oh, you need to see a cardiologist." And the guy's like, "Why? What are you talking about? I feel fine." So, but he got sent to my partner. And this was the cardiogram when he came to my office. So those of you who have some experience in reading ECGs, I think you'd recognize this immediately. I always say sometimes there are certain things in electrocardiography that just kind of jump off the page. So anyone who wants to put their nickel down is welcome to make a comment. I'm sure you all have it. Wyatt was the first one to say atrial flutter. Now, would you say that this is a typical atrial flutter or atypical? Anybody? So, good morning, Roberto. Thanks for joining. Let me use my little, see if I can write on this thing. So, you actually have a heart rate that's in the range of about 80. And so his heart rate was perfectly fine. But when you ask him, "Do you ever get palpitations?" he'd say no. Narayan, I think you meant to say atrial flutter. He had no symptoms of palpitations. He didn't feel his heart racing or anything, but he did admit that for the last couple of months, whenever he'd walk up a hill, he would get out of breath. Now, this started with the allergy season. He had some nasal congestion. He had some difficulty breathing, especially at night. He was snoring a lot. And he just sort of shrugged off the symptom of shortness of breath to just his allergies. But Sandeep has it. It's typical counterclockwise flutter, and the reason that he's not symptomatic from it is that the heart rate is relatively slow. But how do we recognize typical flutter? You know, I like to call this the Black and Decker syndrome, because it was in the U.S. there's a company known as Black and Decker. They make tools. They make saws and hammers and wrenches, and so you have this classic sawtooth pattern. I mean, just kind of looking at it, it's easy to recognize. But what makes it typical is that the flutter rate is a little faster than 300 beats a minute. I think it'd be 320. And it's conducting 4 to 1. You have, if you start on the QRS, you have 1, 2, 3, 4 flutter waves for every QRS complex. So we have 4 to 1 flutter, and the atrial rate is 320, which gives you 4 to 1 gets you 80 beats per minute. But it does have this sort of typical appearance of a sort of a down-sloping signal that kind of peaks, and then there's sort of a rapid recovery before it comes back down again. So you have these downgoing flutter waves in the inferior leads, and you have upgoing flutter waves in V1 and V2. So when the inferior leads in V1 and V2 go in opposite directions, chances are you're dealing with typical flutter, which comes from where? Anybody know? Well, I know that there's like about a 3-second delay, so I won't expect everybody to chime in. But it comes from re-entry around the tricuspid annulus. And just want to make sure my stream is doing okay. So if you're looking at the heart from below, and you have your mitral valve and you have your tricuspid valve, then clockwise flutter is going around the tricuspid valve in the right atrium. Now, depending upon what direction it's going, if you're looking from below, it usually will go in a counterclockwise direction. And since it's going up from the feet, you get the flutter wave progresses away from the feet. That gets you negative flutter waves in the inferior leads, okay, because it's going away from the feet. And if it's going in the opposite direction, if it's going in the clockwise direction around the tricuspid valve, then that gives you upright flutter waves in the inferior leads. And usually in V1, you'll get negative flutter waves. And still in the range of like 220, maybe up to 350 beats per minute. So cavo-tricuspid isthmus is the isthmus of tissue between the inferior vena cava and the tricuspid annulus. And that right there is generally the target for ablation. If you can burn across this isthmus, that basically blocks the circuit. So we've talked about this. I've done live streams with atrial flutter before, and so you guys understand that. Great. But do you notice anything interesting? I mean, why is this guy, he's only on amlodipine. So why do you think he's going so slow? I wonder. It's almost like there's something wrong with his AV node because normally wouldn't atrial flutter conduct really rapidly? I mean, a lot of times people present with 2 to 1 flutter to the emergency room, and he's on no medications, and his atrial flutter is conducting relatively slowly at rest. So that's kind of why my partner decided to order a Holter Monitor. Now, what else would you do with the guy? You don't want to necessarily leave him in flutter forever, and so the first thing you would think about doing is putting him on anticoagulation, right? Because whether you decide to do a flutter ablation or a cardioversion, either way, you're going to need to anticoagulate the patient for a minimum of 3 weeks to make sure that he doesn't have a clot in his left atrium. And when you're going in and doing your ablation or your cardioversion or whatever. I'm just curious. I have like two screens and I'm looking at multiple windows, and my my live view of YouTube is sort of a little fuzzy. Would you guys just make a comment to make sure that everything's okay? Because it looks like my stream is good, and I'm always sort of concerned. I'm by myself, by the way. I don't have like a crew. I don't have like technical people surrounding me. I'm just sort of like here managing everything, so I have to think of a million different things. So if you guys want to just make a comment, just say looks clear, everything looks okay, just please let me know. Anyway, so a lot of times I see these technical glitches and everything seems to be fine. Sound is choppy, Elizabeth? Okay. Well, the sound is sort of usually the takes up the least amount of data. But anyway, so we did put him on anticoagulation. We started him on Eliquis. And everything's okay, says Brian. Thanks. So we started him on Eliquis, 5 milligrams twice a day. And my partner decided to get a Holter Monitor, and that's what she kind of threw onto my desk. So let me show you what the Holter showed. Now, interestingly, the average heart rate was about 100 beats per minute. But you can see when he does, let me put this up here. Here's an example from the Holter. And in the top strip, you can see very clearly that we have 2-to-1 conduction. The atrial rate is like 320. The ventricular rate's about 160. And let me just get my opacity up here. So we have about 160 beats per minute. And we have, so you can see one flutter wave in between the QRS complexes, but the other flutter wave is kind of buried in the QRS. So this is pretty typical for 2-to-1 flutter. But that was at like 8 o'clock in the evening. I think he ran up a flight of stairs, and this is probably why he's getting out of breath, is when with atrial flutter, any change in your autonomic nervous system has immediate effect on the AV node. And in the case of doing any kind of exercise like walking up a hill or climbing stairs, your sympathetic nervous system increases and your AV node conduction is enhanced. And then you have this, situation where you have 2-to-1 flutter. And with such a rapid rate, you compromise diastolic filling, don't you? So your cardiac output suffers, your blood pressure can sometimes drop. And that's why a lot of people will get symptomatic when they are in 2-to-1 flutter. But then 11 o'clock at night, 11:26, you see this where he's back to 4-to-1 and it looks fairly regular, and he's asymptomatic at this point. But then I flipped the page on the Holter Monitor, and this is what I saw. Oh, well, it's almost kind of like the Flatliners Club. You have QRSs, here's one here, and then there's one way over here, and there's nothing in between. And this adds up to like 4.5 seconds, which in reality is a heart rate of about 15. So it's a little slow. But when did this happen? It happened at 6:50 a.m. and he was sleeping at the time. Now, if you notice, there's 3 strips here. This is at 2:20 a.m. and he has another one of these really long pauses, over 3 seconds. And then here at 4 o'clock in the morning, he gets very slow. But when you look at the big picture, look at the strip, look at this part down here, and you can see he's going at like maybe 5-to-1, and then he has this long pause, and then he's very rapidly back to like 3-to-1. So he recovers very, very quickly. And again, in this strip, he's sort of kind of fast, and then he has this long pause, and then he's really, really fast again. And same thing here. It's almost like the severe bradycardia is intermittent. So now, would anybody call this Tacky-Brady syndrome? So would anybody call it Tacky-Brady syndrome? I would not. And the reason I would not call it Tacky-Brady syndrome is because the definition of Tacky-Brady syndrome is it's a variety of sick sinus syndrome. you have to have sinus node dysfunction with sinus bradycardia and paroxysmal atrial arrhythmias like atrial flutter fibrillation and so forth, or even atrial tachycardia. So you have the tachy and you have the brady. What is his sinus node doing? We don't know. He's in atrial flutter all the time. So we really don't know what his sinus node is capable of. We can't really say that he has sick sinus syndrome. So it's not really tachy-brady. What it is simply persistent atrial flutter with a very labile ventricular response. So what part of the conduction system is misbehaving? You know, if this guy had a bundle branch block or bifascicular block or left bundle, I could see how you might say, well, maybe his his bundle is hanging by a thread and he has these long pauses, and he's a guy who may need a pacemaker because of perhaps the risk of syncope. I mean, we've talked about that. I showed you, there's a live stream on trifascicular block. I have other live streams about type 2 second degree AV block where the problem is below the His bundle and you have lousy escape rhythm. But that's not what's happening here, I don't think. Anybody have any ideas? Why do I agree I think he has some AV nodal disease, which is why his heart rate at rest is relatively slow. But remember that with rapid atrial rates, you get more concealed conduction in the AV node. With rapid atrial rates, the AV node conducts worse. That's why premature atrial beats will sometimes conduct with a first degree AV block, or they may even fail to conduct. And that's why people with atrial flutter or fibrillation tend to conduct a little bit more slowly when the atrial rate goes up. So for example, with atrial flutter, you can conduct maybe 150 beats per minute, but if that person goes into atrial fibrillation, they may only conduct at 130 or 120. So the idea that the AV node conducts worse with faster rates, known as concealed conduction or decremental conduction, is a common idea. I've talked this, I teach this in my course, try to get you guys to understand how the AV node behaves. I'm looking at the screen, and Madeline, right on the money. That's what I think this is this is sleep apnea. Because the AV node is a team player, and it gets signals from the sympathetic nervous system, from the parasympathetic nervous system, and it behaves poorly in the setting of hypoxia. And if you have transient hypoxia in the middle of the night, and that's going to affect not only the sympathetic nervous system, but also the autonomic nervous system, but it's also going to directly affect the AV conduction. So Elizabeth was thinking about it too, and that's what I was thinking about. In fact, recently the ACC, I think, published new guidelines, or maybe it was the European cardiology, where they were talked about the indication for pacemakers in people with sick sinus syndrome. And what they made a point about is that when you see extreme bradycardia that's limited to the hours of sleep, you really need to think about sleep apnea. Not only that, but the fact that you have a young person, 60 years old, with atrial flutter, sleep apnea definitely predisposes people to developing all these things. So maybe he needs CPAP, but does he need a pacemaker? How many people would decide to implant a pacemaker? Show of hands? I'm not seeing any hands. That's pretty good. I'm glad I don't see any hands, because I would not put a pacemaker in this fellow. First of all, let's just say that he had atrial flutter, and having bradycardia in the middle of the night while you're sleeping, really your best bet is to just treat the underlying problem. So CPAP or BiPAP would probably be a good thing. It would fix this bradycardia. But I don't think the bradycardia is the problem. I think his tachycardia is the cause of his symptoms. So they did, my partner did decide to put him on metoprolol, just to kind of keep those rapid rates from from getting the better of him. But then what would you decide to do with this fellow? I mean, I certainly wouldn't leave a 60-year-old fellow in atrial flutter. I think that's not doing him any favors. And it's typical atrial flutter. So the easiest thing to do is just to recommend a flutter ablation. So at any rate, what we did was we waited 3 weeks and saw him in the office. And the problem is this, that after 3 weeks, this is kind of what we found. So Sadip, that's a very good question, cardioversion versus ablation. So this is the first episode of atrial flutter. He's only 60 years old. The data shows that if you do cardioversion and use antiarrhythmic drugs, that the risk of recurrence within 2 years is somewhere around 75 or 80%. Whereas if you do a flutter ablation, the risk of recurrence is like 10%. So ablation is definitely superior to just cardioversion and medical therapy. And I had scheduled him for a flutter ablation. And I definitely would have gone ahead with it, except he came into the office like 2 days before his scheduled procedure, and this is his ECG. So as you can see, things have changed. Yeah, it looks like AFib now. So what do you think happened? Did his heart disease get worse? You know, I think someone who's in atrial flutter, what happens is there's electrical remodeling that goes on when you have a very rapid heart rate. I mean, we know from experiments, done in the 1960s that when the atrium is beating very rapidly, either because of rapid pacing or because of atrial flutter fibrillation, we know that the atrial cellular refractory period shortens. So it becomes pro-fibrillatory. With a shorter refractory period, you can get faster rates and you can sustain atrial fibrillation, and it's more likely. That's where the expression atrial fibrillation begets atrial fibrillation came from. Is that when you have this rapid heart rate, the electrical remodeling occurs and shortening of the refractory period encourages AFib. So I think that's what may have happened, is that his atrial flutter degenerated into atrial fibrillation because it had been going on now for perhaps a couple of months. So now he has atrial fibrillation. Now what do you do? Do you recommend an AFib ablation? A lot of places where they do a lot of AFib ablation would consider doing that. Frankly, I don't consider atrial fibrillation as first-line therapy yet. I think the long-term success rate is still somewhat disappointing. I think the risk of atrial fibrillation ablation is significant. In a young person, there's still a 2 or 3% risk of serious complications, tamponade and so forth. I think places that have good experience will still tell people that there's at least a 20 or 25% chance that they'll have to have the procedure repeated. And so I thought that with this guy, it was the first time he had an arrhythmia. He's only 60 years old, and I decided to go for just a cardioversion. So if he had been an atrial flutter, I would have ablated the flutter, no problem, because it's a low-risk procedure. It takes like an hour. Honestly, it's like a slam dunk. It's like, low-hanging fruit, as they say. So doing a flutter ablation would have been a no-brainer. But now that he's in atrial fibrillation, I decided to just do a cardioversion. So we did actually do a TEE because he may have skipped a couple of doses here and there. So we did a TEE, and we can see there's mild concentric LVH. His ejection fraction was normal. There was no thrombus. He had a little bit of valvular heart disease. So it wasn't entirely normal, but it wasn't bad. So I went ahead and did a cardioversion with 100 joules, and then this was the result. Look at that. And this is on metoprolol. So his, sinus rate is like about 85 or so. His PR interval is normal. There is a suggestion that maybe he has electrocardiographic evidence of left atrial abnormality because he has this sort of like deep negative component to the P wave in V1. And he does have like a little bit of a hint of P mitrale. But interesting, when you look at the TEE, did it say the left atrium was enlarged? It said mildly dilated. So anyway, his, I'm getting a little hoarse. Why is that? I think it would be a pony. Wouldn't that be a little horse? Never mind. So anyway, we were happy to see that he was very easy to cardiovert, one shock. He's back in sinus rhythm. So at that point, we were going to send him home, and we were going to. I noticed that Sadeep asked a very good question. Patients with fib and flutter, can you do a flutter ablation and cardiovert on the table? I thought of that. Actually, that's a very good thought. I thought of, we'll just bring him into the EP lab. We'll put wires in. He's under deep sedation. He's getting propofol, Diprivan. So we'll shock him back into sinus rhythm. And then we'll just ablate his isthmus and maybe solve the problem. But I kind of, I was a little reluctant to do that. I wanted to see what happens mainly with this fellow, because if he winds up going into recurrent atrial fibrillation, then he'd be better suited having a fib ablation, and then they could burn the isthmus at the same time. And I don't like putting people through multiple invasive procedures. I just thought that the simplest thing to do, and maybe the safer thing to do, would be just do a cardioversion. But now I didn't want him to go right back into fib or flutter or anything. So I decided, at least for the short term, to stop the metoprolol and put him on sotalol. So I did go ahead and start him on sotalol, 80 milligrams twice a day. And he came to the office like 3 days later, and here's his cardiogram in the office. So now his heart rate's a little bit better. It's about, 72 or so, 75. Well, maybe it's a little less, maybe about 68. His PR interval is normal, so his AV node is behaving perfectly fine. His QT interval is normal, so the sotalol did not have any adverse effects. And he felt great. He's sleeping better now. He actually is able to climb stairs and walk up hills with less shortness of breath than he used to. And this is a good thing. So what I said to him is he needs to stay on Eliquis for 3 more weeks, and that's the recommendation, because we know that after cardioversion, the atria can be stunned. And it could take at least a week or so for normal atrial contraction to occur. So you want to make sure that he doesn't form a clot. We know that cardioversion, it can actually be thrombogenic. That means that people can develop a clot after the cardioversion. So we maintained Eliquis for 3 weeks, and I told him that I would leave him on sotalol for maybe 3 months. And at that point, provided he didn't have any recurrences, I would feel comfortable taking him off of the sotalol and just treating his hypertension, and then maybe getting him a sleep study, because I think that ultimately would do him a lot of good, since it's conceivable that sleep apnea really is what triggered this whole thing. Now, the fact that his atrial flutter is a little bit slow, makes me think it's possible that he has some underlying conduction disorder. And then when I talked to him about his family history, it turns out his brother has atrial fibrillation. So how do you like that? So there may certainly be a genetic component to this whole thing. A part of cardiology that we don't yet understand. But I mean, that's something that we can explore with research down the road. I wouldn't necessarily do anything different for him, but I certainly would kind of keep an eye on it. I told him that he should learn to check his own pulse, that if his symptoms were to recur, that he needs to come back and see us right away. I don't know about you guys, but there are tools, there are kind of like home heart monitor devices that you can buy. I know there are a lot of devices that you put your finger on, and you can actually see your own electrocardiogram. They work with smartphones. There's a company here called AliveCore that I think was one of the first, but there are a lot of other companies now that are manufacturing these little gadgets that you can just put your fingers on and record like lead one and see what's going on. Of course, if you're a fan of the Apple Watch, that now has the ability to record your own ECG, and people can learn to keep track of themselves. I mean, I think nowadays people feel more empowered to take charge of their own health care, and I think that teaching patients how to monitor themselves, whether it be home blood pressure machines or monitoring their pulse rate. Sometimes I tell people to buy a pulse oximeter. They're like $15 on Amazon.com so that they can check their heart rate every now and then. I think that gives people not only a sense of accomplishment that they're monitoring themselves, but they can pick up things a lot sooner than they will if coming to the office every 3 months, and then they could let the doctor know, and you can take steps quicker. Because we know that atrial fibrillation, the longer you let it go on, the more difficult it is to get rid of. But just kind of like keep an eye that atrial flutter is a little bit of a different animal. And in this case, it was certainly easy to get rid of. Now, if he develops atrial flutter again, then I wouldn't hesitate to do the flutter ablation. If he develops atrial fibrillation, I try at least one antiarrhythmic drug, or maybe two, before I refer those people on for ablation. But some people have a very low threshold for ablation because we know that antiarrhythmic drugs have negative side effects. So it's weighing risks and benefits just like anything in medicine. So I'm glad that you guys are engaged, and I really appreciate all of you spending your Saturday morning. It's 33 minutes. I think I've kind of got the point across, and I certainly appreciate your being here with me. And if you like this type of content, put some positive comments down below. Give me a thumbs up in the comments section. Subscribe and let your friends know. Let everybody know, whoever you can, that I generally do this most Saturday mornings, and it's fun. But I hope that I'm kind of helping you learn how to manage patients the way a specialist does. So until next week, this is Dr. Nick Tullo. Thanks for joining me, and hope you have a terrific week.